Hello, my name is Rachael Carrero. I'm a third-year student at DePaul in the Clinical Mental Health Counseling Department, and I'm going to talk today about mindfulness-based cognitive group therapy. So I just wanted to touch base on the rationale for the project. There's been a lot of good research done on MBCT used as a group in the past 10 or so years that really supports its use for lowering depressive relapse risk as well as lowering risk for other psychiatric conditions as well. In short, to define mindfulness-based cognitive therapy, it's essentially incorporating elements of CBT with elements of mindfulness-based stress reduction. I really wanted to use this just because I utilize both of those interventions a lot at my internship site in my personal life. The biggest difference being it's different from cognitive behavioral therapy in that we are putting little emphasis on changing the thoughts, but rather just relating to them differently. So my setting was done at an IOP level of programming. There were 3 participants, all were female, heterosexual, Caucasian, and from the ages of 20 to mid-40s. All of them are from a relatively similar middle-class background, their primary diagnoses being GAD and MDD. So MBCT Group Format typically is held over 8 consecutive weekly sessions at about 2 hours length each. My original format was to be similar to this, doing 8 consecutive group sessions over 4 weeks instead of the 8 weeks, 2 group sessions per week instead of the one at about 45 minutes to an hour length. Um, Unfortunately, my site closed down due to low census as well as difficulties with COVID-19 back in April, so I only got to do about 2 weeks, which is about 4 groups of the MBCT group format in total. So my groups were made up of a lot of mindful practice, such as meditation practices, guided body scans, sitting and walking meditations, mindful movement, 3-minute breathing spaces, and focused awareness of daily activities. I also incorporated some psychoeducation through using worksheets and handouts based off of the book Mindfulness-Based Cognitive Therapy for Depression, as I mentioned in the slide. And I also assigned daily homework as well and encouraged our participants to keep up on their own practice on the days I didn't assign homework as well. So, when looking at psychological measurements for this study, I wanted to look at levels of depression and panic since our subjects are primarily struggling with that. So, to do that, I used our treatment outcome package or TOPS assessment that we normally use for all of our patients at my internship site. It's a 58-item questionnaire. It covers a lot of different domains such as daily living, social life, symptoms, etc. It takes about 8 minutes on average to complete. And normally we would measure them when they first come into program as well as in the middle, and then also at discharge to see any progress of those levels as they go through treatment. So this is just a basic example of the TOPS assessment that we give our patients for the adults. Just to highlight, all of the little squares are different domains, and the bars would indicate how severely they're struggling with each domain and how severely they're not struggling with each domain. So just to point out, one of the closer lines to the bottom is the general U.S. population, where they're kind of at in those different domains: social functioning, suicidality, mania, depression, panic, etc. So anything above that line in terms of bar format would indicate an area of struggle or problem. Anything below that line would actually be an area of a strength. So for the sake of time, I'm only going to look at one patient's TOPS results that are individual. So as you can see, I put arrows by the depression and panic domains just because those are the domains I was looking at. So her depression levels came down quite a bit from the first examination to the second one, and her panic symptoms only came down a little bit from the start to her discharge date. So within this bar graph, I compiled the average results of all 3 of the participants of their depression and panic level scores. So the light blue bar representing their scores at admission for depression and panic, and the dark blue bar representing their scores at discharge for depression and panic as well. So we can see both levels came down for both panic and depression, more so for depression, and also to notice that panic levels in our participants were much higher than those of the depressive levels. And I did want to take some time to talk about observed confounds of my study, one being that there's a small sample size, only 3 people, with a limited demographic. They're all kind of the same demographic. There was a usage of a broad assessment tool. So, what I mean by that is with the TOPS, it's a 58-item questionnaire, yes, but it looks at many different domains. I only chose to focus on the depression and panic domain. So, using that broad tool to look at just 2 domains. 50% of the original sample either discharged early or were stepped up to inpatient, etc. So, could not complete the whole group structure. There was a limited group format due to the site closure. So when my site closed, I only, got an opportunity to do 2 weeks out of the 8 weeks I had planned. And then lastly, other groups and scheduled programs could have affected the treatment results as well. So we do a lot of different groups, DBT, CBT, so that as well could have influenced the levels of depression and panic. Thank you for listening to my presentation. It was really awesome to get to be able to lead an MBCT group, even for the short time that I did. I feel that groups can be very transformative, and mindfulness strategies and CBT strategies coming together, I think, is just a very powerful experience for all who can be involved. And that's it. Thank you very much.